Hey, welcome back to part 2 of our chronic conditions lecture. In the first session, we focused on cardiovascular, respiratory, GI, and GU issues. Today, we're going to dive into our musculoskeletal as well as integumentary and neurological disorders. These are some of the most common reasons that people in our region lose independence and require the long-term support, or that they're readmitted to the hospital. When we look at chronic diseases in our region, remember that Western North Carolina has one of the highest portions of adults over 65 in the state. They all want to retire here because it's beautiful. So that means arthritis, wounds, and cognitive decline are not just topics in a book. They are patients that we are going to see every week in the field. Our musculoskeletal conditions are among the most common chronic issues in the U.S., so arthritis in particular affects more than 54 million adults and is the leading cause of disability nationwide. In our region, with one of the oldest populations in the state, arthritis impacts mobility, independence, and the quality of life more than almost any other chronic condition. Patients with arthritis often face challenges completing daily tasks and are at a greater risk for falls and those hospitalizations, as well as depression if we don't manage their symptoms. Arthritis is not a single disease, but it is a broad term, and that includes more than 100 types of joint inflammation issues. So as CPs, our role is not to diagnose, but to recognize the symptoms and help manage them effectively. Care usually centers on providing education, teaching symptom relief strategies, supporting their mobility, as well as monitoring for any worsening disease issues. If care is fragmented, patients can quickly spiral into immobility. Then there's weight gain and isolation, all of which increase their risk of hospitalization or placement in a long care facility. Two forms of arthritis are especially common in the community paramedic setting: osteoarthritis and rheumatoid arthritis. So our osteoarthritis is the wear and tear form. That's what we see most often with our older adults, while rheumatoid arthritis is actually an autoimmune disease. That one requires more complex management. In our region, osteoarthritis dominates because of the region's older demographics, but RA patients also present struggles and barriers because our specialists are mostly based in our higher population areas such as Asheville or Greenville. Osteoarthritis is the most common. Like we said, we see that's the natural breakdown. Nationally, it affects over about 30 million people. It's especially disabling when it impacts our knees, our hips, or our hands, joints that we rely on daily. In our region, this means patients struggle to get to their mailbox, to attend church, or continue gardening, which are important activities for both physical as well as mental health. Without proper management, they may withdraw from social life and there in turn lose their independence. Radiographic findings in osteoarthritis often confirm this diagnosis. This includes our uniform joint space loss, osteotype formation, cyst, calcification of our cartilage, and our subchondral scoliosis. So as community paramedics, we won't be reading films, thankfully, but understanding these findings does help us recognize why a patient's pain or stiffness is not just normal aging. When patients feel their pain is minimalized or even ignored, they are less likely to engage with us and less likely to be proactive with their care. They may also overuse their pain medications or stop moving altogether. Monitoring for osteoarthritis should focus on inflammation, limitations in movements, crepitus or bone crunchies, painful movement in both active as well as passive range of motion. These are often small changes that patients ignore until their conditions worsen. In Western North Carolina, patients who live in rural areas, which we have a lot of, they tend to go without follow-up because they don't have reliable transportation. So they miss their follow-up care. If mobility issues aren't identified early, they can quickly cascade into falls, injuries, and those hospital admissions. Management of osteoarthritis emphasizes gentle, regular activity. Patients should exercise at least twice a day, but they need to avoid activities that cause pain lasting more than 2 hours. Supports like braces or orthostatics can help. We can also help with their weight loss and set up a program for them and monitor the use of NSAIDs. Local physical therapy programs through our local partners such as Party or Mission often provide arthritis-specific exercise plans, but many patients struggle with the cost or that transportation. So without encouragement from you guys, and accessible resources, patients may stop their program and worsen their disease progression. Education for osteoarthritis should focus on helping them understand both the seriousness of the disease and the steps that they can take to manage the disease. Encouraging patients to log their symptoms is simple, but it's also effective. This gives them a sense of control and provides valuable information to us as well. Without structured education, patients often believe arthritis is an unavoidable part of aging and they fail to engage in preventative strategies. This leads to a faster decline and greater disability. On to our RA. So rheumatoid arthritis is that chronic autoimmune condition. It affects about 1.5 million people in the United States. So unlike osteoarthritis, which is a mechanical, RA actually involves systemic inflammation. Patients may initially present with stiffness in the morning or fatigue, even when pain is minimal. RA patients face particular challenges because specialists are concentrated in urban areas, as we mentioned, so there has to be coordinated care. Without it, patients can quickly progress from mild symptoms to severe disability, often within just a few short years. As RA progresses, patients may develop deformities such as the hammer fingers, or boutonniere deformities, or toe flexion problems. These changes are not only painful, but also deeply impact daily functioning, from dressing themselves to opening pill bottles to preparing meals. When the care is inconsistent, these deformities can progress unchecked, leaving patients dependent on family or caregivers or even the simplest and mildest activities. This loss of independence can be devastating emotionally, particularly in older adults who pride themselves on self-sufficiency. A diagnosis of RA is made using a combination of differential diagnosis, so lab tests as well as imaging. Community paramedics won't be ordering these, but we can recognize patterns and ensure patients follow through the specialist referral. Delays in their diagnosis are common because of the limited access to the specialist in our region. When diagnosis and treatment are delayed, irreversible joint damage can occur, and that damage could have been slowed or even prevented with earlier care. So management is complex for RA and requires coordination between multiple providers. Medications often include our disease-modifying anti-inflammatory drugs, so our DMARDs, biologics, corticosteroids. These treatments may take weeks or months before patients even feel relief. In rural Western North Carolina, access to infusion centers or specialty pharmacies is very limited, and that also delays therapy as well. They need consistent management, otherwise these patients face rapid progression of joint destruction, chronic pain, and dependence on caregivers, outcomes that drastically reduce their quality of life. So education is key, as always. Patients should be encouraged to keep daily symptom diaries to track their flare-ups and the medication effects as well. So there are also support groups through Mission and Party. I did not know about that till recently, for people that have RA. So these groups provide both information and emotional support. So proper education is key. Otherwise, these patients often lose hope. They skip medications when they don't feel immediate results, and that increases their risk of long-term complications down the line. On to our skin, our largest organ. The integumentary system is our body's largest organ system, and skin conditions often reflect your overall health. Chronic wounds and skin breakdown are very common with older adults, with pressure ulcers alone affecting more than 2.5 million patients each year in the United States. We have a lot of elderly patients here that live alone in rural homes. Skin breakdown may go unnoticed until it becomes infected or life-threatening because they're not getting checked like they should. CPs are often the first to identify these problems during your home visits. Wounds can be classified into several categories. You guys should be familiar with these: the contusions, abrasions, lacerations, and ulcerations. Each type is different. There's different healing patterns and risk that's associated. For example, abrasions may seem minor, but can quickly become infected if they are neglected. Our ulcers, there you go, that was for you, Ryan Brown. By the way, Ryan Brown is starting a drinking game. Anytime I stumble over a word, he has to take a shot, so I can give you his contact information if you would like to be a part of it. I'm not condoning alcohol. But our ulcers, especially venous or neuropathic ulcers, are slow to heal and often reoccur. If these wounds are not managed correctly, patients may require repeat hospitalizations, which lead to a loss of independence and sometimes even amputations. Contusions. So these are bruises that don't have a break in the skin. They often resolve on their own, but they also can signal an underlying bleeding or clotting issue, especially on the patients that are on our anticoagulants, which are very common in our region. In elderly patients, repeated contusions are sometimes mistaken for normal bruising, but may also indicate elder abuse or falls that maybe they're not reporting. So without careful follow-up, these patients may continue to decline silently. Abrasions are those superficial wounds caused by scraping of the skin. These are usually painful and prone to infection. So patients with diabetes, poor circulation, even a minor abrasion can become serious. So our rural counties, delayed care often means an abrasion develops into cellulitis before treatment is sought, which results in unnecessary hospitalizations. Lacerations are deeper wounds caused by sharp cuts and tears. They often require suturing or surgical repair. For CPs, the role is not to close these wounds, but to recognize when a referral to urgent care is necessary. And in really rural areas like Polk or down the mountain, delays in getting to wound care centers or emergency departments can result in poor healing or infections, which adds to healthcare costs and patient suffering. Ulcerations and the chronic skin breakdowns are often linked to vascular diseases, neuropathy, or immobility. Our venous ulcers are commonly associated with chronic venous insufficiency and DVT history. Neuropathic ulcers are common in diabetic patients, and pressure ulcers occur in immobile or bed-bound individuals, very common in nursing facilities. In our area, pressure ulcer rates hover around 6 to 10%, but in community settings without oversight, the numbers are likely higher and are not going reported. The presence of chronic wounds dramatically increases morbidity. Infections from untreated ulcers can progress into osteomyelitis or even sepsis. Patients with limited mobility and limited caregiver support are most at risk. When CPs intervene early by checking pressure points, reinforcing nutrition, and educating on daily skin checks, these patients can avoid the hospitalizations. So without these supports, many end up requiring amputation or placement in nursing facilities. Well, that's a pretty toe. Wound management includes preventing further injury, optimizing nutrition, and maintaining the proper wound environment. Adequate protein, vitamin C, and hydration are especially key for healing. Locally, wound care centers at Pardee and even, yes, Advent Health, aka formerly known as St. Luke's down the mountain in Columbus, they provide specialized services, but many rural patients cannot travel frequently. Without guidance from community-based providers, wounds are often neglected until they can't reach those advanced stages. So, community paramedics should always assess a patient's potential for skin breakdown. That includes evaluating their mobility, checking their skin daily, and getting them to check their skin daily, looking for redness and pressure marks. Patients with diabetes, neuropathy, or chronic immobility are at the highest risk. If these early warning signs are missed, the patient may develop severe wounds that are both painful as well as expensive to treat. Education for caregivers and patients is one of the strongest tools we have with all things, and definitely counts for wound prevention too. Teaching patients how to reposition every 2 hours, inspect their own skin, and use proper bedding or cushions can prevent the ulcers from forming. In Western North Carolina, we have places like the Area Agency on Aging. They sometimes provide equipment such as pressure relieving mattresses. So without education, these resources, wounds often reoccur even after the initial healing has begun. Re-injury is a common problem. Patients who have already had one ulcer are more prone to develop another, often in that same area. This is particularly true for diabetics who may lose protective sensation in their feet. So without constant follow-ups, these patients cycle through repeated wounds, hospitalizations, and eventually those amputations. Nutrition, nutrition, nutrition. If we are not properly, if we are not properly fed and we don't have the right nutrients, we cannot heal wounds properly and correctly. Patients with those poor diets, dehydration, limited access to fresh foods heal much more slowly. In rural counties, food insecurity is very common, which compounds this issue even more. CPs should assess diet and connect patients with resources like food pantries. Programs like Meals on Wheels are huge. Without nutritional support, even the best wound dressing isn't going to help with healing. Excuse me. Creating the right wound environment means balancing moisture, preventing infection, and avoiding further trauma. This often requires specialized dressing or topical medications prescribed by providers. Also, our Buncombe County EMS folks had some pretty cool things that they had in their wound kits. That information is loaded up on your course shell. So if you're curious as to what they use, please pop in there and check. Now, do you remember anything that you have in your wound care kit that you are applying to patients does need to be given access to, or you do need to have a protocol in place by your medical care director, your medical director. So in our region, patients may not always have access to advanced supplies or even basic supplies. So education on basic care is very key. When wounds are left untreated or cared for improperly, patients experience chronic pain, infections, and repeated visits. So all which could have been prevented with consistent care and education. On to neurological conditions. Neurological conditions are some of the most life-alternating chronic diseases that we see. They impact cognition, movement, as well as independence, and many of them progress over years. In the U.S., nearly 1 in 6 people live with some form of a neurological disorder. In Western North Carolina, where the population is older, dementia, Parkinson's, and stroke-related deficiencies are particularly common. If these conditions are not addressed, patients often lose the ability to manage their own health, leading to those frequent calls. Cognitive decline is something that we see quite frequently. So our cognitive decline can begin with small things. They have small memory lapses, poor judgment occurs, personality changes. About 11% of adults over 65 in the U.S. have Alzheimer's or another form of dementia. In Western North Carolina, the percentage is even higher due to our older demographic. If decline goes unnoticed and unrecognized, patients may forget to take their medications, leave their stoves on, or wander off from their homes. Situations that place them and their families at a significant risk. As community paramedics, we are in a unique position to identify early warning signs. Patients may seem confused during a routine visit, or caregivers may mention changes in their behavior. Early detection allows for interventions that slow decline and connect families with resources early on. Without this, patients often reach a crisis point before anyone even realizes that help is needed. This leads to ER visits and dangerous home environments. So dementia is an umbrella term for several conditions, including Alzheimer's, vascular dementia, and Lewy body dementia. Alzheimer's is the most common, we're all familiar with, but all forms involve progressive loss of memory, reasoning, and then independence. In our area, we have many seniors that live alone in rural locations. Dementia can progress unnoticed until neighbors or EMS are called repeatedly for those welfare checks. So these folks should be flagged in your system, so that way our CPs can go back out and set up some sort of program for them. So we do play a vital role in supporting both patients and caregivers. We can reinforce medication schedules, encourage safe routines, and connect families to support services like the Alzheimer's Association Western Carolina chapter, which is another one I didn't know about until I started exploring this program. Without interventions, dementia patients often cycle through EMS and hospital admissions until they are eventually placed in long care term permanently. Alzheimer's disease alone affects more than 6 million Americans. It's progressive in stages from mild memory loss to severe cognitive decline, where patients cannot perform even the basic self-care routines. In rural Western North Carolina, families often struggle to manage at home because professional memory care facilities are very limited outside of Asheville, or they're just not so great at all. When families are overwhelmed, patients may end up in repeated crisis where you have calls that keep coming in for our same patients. Early education, once again, very key. In the beginning stages, we can teach patients strategies to help stay independent, like little written post-it note reminders or a safe medication system. Later stages shift the focus more towards caregiver support. Without the support, caregivers experience high stress depression, which directly harms the patient's quality of life. Respite care programs through the Council on Aging or local faith groups can help provide relief, but families need help navigating these resources. We didn't even know about our own resources we had in our backyard. Imagine how many else are out there that don't know. Alzheimer's disease progresses in 3 major stages. We have mild, moderate, and severe. Each stage brings a different challenge for both the patients and the caregivers, and understanding these stages helps us guide families through what to expect. In the mild stage, patients may still function fairly independently. They might forget names, misplace items, or struggle with planning tasks like paying the bills or cooking. In our region, families often chalk these changes up to normal aging, which means our diagnosis is then delayed. So without early recognition, patients miss out on interventions that could have helped preserve independence longer. The moderate stage is where symptoms become much more noticeable. Patients often lose track of time, forget close family members, or may begin to wonder. They may also develop mood swings or behavioral changes that are hard for families to deal with. Caregivers in this stage are at a high risk of burnout. In our region, especially in our rural counties, once again, the lack of memory care programs means families often manage on their own until a crisis forces hospital admission. The severe or end stage is when patient loses their ability to communicate clearly. This requires help with they require help with the basic activities of daily living, or ADLs, and often become bedridden. Complications like pneumonia, malnutrition, or infections are common. In Western North Carolina, where access to hospice and long-term care beds is limited, families struggle to provide end-of-life care at home. Without adequate support, patients and caregivers alike experience unnecessary suffering. Alzheimer's just isn't about memory loss. It's about the gradual loss of independence and their dignity. Understanding these stages helps us as community paramedics anticipate needs, provide education, and connect families when available with local resources like that Alzheimer's Association Western Carolina chapter or respite care through the Council on Aging. By stepping in early, we can help slow decline, we can reduce crisis, and preserve the quality of life as long as possible. So, management is primarily geared towards recognition of the symptoms, recognition of changes in symptoms, monitoring for progression of the disease. Many behavioral and pharmacological treatments are available for the disease, but there is no cure. Medications are prescribed in the early stages of dementia, and they may include cholinesterase inhibitors such as, I'm not even going to try to say this, arsorapet. Okay, there's 3 of them. I'm not going to pronounce them for you, but there are 3 medications that you may see commonly with Alzheimer's disease. So there are treatments for moderate as well as for our later stages of Alzheimer's, but once again, it comes down to actually identifying this early, getting them in for a diagnosis, and then starting the treatment from there. So also keep track of alternative uses that the patient may be taking. So herbal remedies, dietary supplements, they also can have a negative effect when used with certain Alzheimer's medications. So navigate the patient and caregiver to local outreach support services to provide additional support as needed. Many resources are available. Please make sure that we are sending them to our local Alzheimer's Association helpline websites, local chapters. Educate them early, and later on we are focusing more on our caregivers. On to Parkinson's. Parkinson's is a chronic neurologic condition that primarily affects movement. It develops when the brain loses its ability to produce enough dopamine. That's the chemical responsible for smooth and coordinated muscle movements. Without dopamine, our motor neurons misfire, which causes stiffness, tremors, and slow movements. So Parkinson's is especially concerning because our older population is at greater risk, and we have quite a few of those. And access to special neurological care is very limited with the exception of our big cities. So without consistent monitoring and early treatment, patients often decline quickly, leading to falls, injuries, and once again, that loss of independence. So the most common symptoms of Parkinson's is tremors, trembling or stiffness in the extremities, slowness of movement, poor coordination or balance. These symptoms may begin subtly: a faint hand tremor, shuffling steps, or reduced arm swinging when they're walking. Over time, they progress to make activities of daily living like dressing, bathing, even riding and opening pill bottles extremely difficult. These symptoms are often under-recognized until patients actually fall repeatedly, and they can no longer care for themselves. So with that continued, we end up having preventable hospitalizations. As Parkinson's advances, symptoms can become severe. Patients may lose the ability to chew, swallow, or even speak. This leads to malnutrition, aspiration pneumonia, and social isolation. Speech therapy and swallowing therapy is something that will help, but it may be difficult to find in your region. Patients often go without the very interventions that could improve the quality of life because they can't find them or don't have access. Without these supports, decline is accelerated and families are left to manage devastating complications with very little guidance. So Parkinson's has both genetic and environmental influences. It affects approximately about 500,000 people in the U.S., with an average onset being around 60 years old. So there seems to be an increase of prevalence, partly due to better awareness and early diagnosis in our region. It is our aging population. Parkinson's is definitely common. And the burden is not just medical, it impacts quality of life, our family dynamics, and our healthcare cost. So when patients don't get coordinated care, the disease progresses unchecked, leading to premature disability and even institutionalization. So the management of Parkinson's is focused on slowing the progression, reducing the symptoms, and maintaining the quality of life. Once again, there's no cure for this either, but several strategies can make a huge difference. The cornerstone of treatment is medication, particularly levodopa and dopamine agonist, which help replace or mimic dopamine in the brain. These medications can reduce tremors and stiffness, but their effectiveness may wear off over time. Patients also benefit from physical therapy and occupational therapy, as well as speech therapy. So connect them with resources. Mission Health in Asheville does offer multiple things for Parkinson's. Just putting that out there for our local folks. So education, once again, is our most powerful tool. So medications and therapies are important, but they need to understand the disease process and how things change. So education empowers families to recognize symptoms, prevent complications, and prepare for the future. There are several excellent national resources: the Parkinson's Disease Foundation, the Michael J. Fox Foundation for Parkinson's Research, and the National Parkinson's Foundation all provide reliable information for caregivers. So there's guides and even online community support. These resources can help families learn about new treatments, research updates, and strategies for living with the disease. Locally, we do have Mission Health in Asheville, and they also have some Parkinson's support group. So the Parkinson's Foundation Carolina chapter is also a good one. They have some outreach and events that are tailored to our region. So even smaller communities like Hendersonville and Brevard often do have support groups through our local senior centers in our churches. On to ALS, also known as Lou Gehrig's disease. It's rare but devastating. It is a neurodegenerative condition. It progressively damages the neurons responsible for voluntary muscle movement. The exact cause is not known, but through both genetic and environmental factors are thought to be suspected with this. Although it's rare, ALS devastates family because once diagnosed, they only live for about 2 to 5 years after that. Our patients often have overwhelming challenges trying to access specialized equipment and neurology care. So without that support, patients lose independence even faster and caregivers experience high stress. Symptoms include fatigue, muscle cramping, fasciculations or twitching, pain, depression, sleep disturbances, and constipation. The progression is relentless, eventually leading to paralysis. Patients often remain mentally sharp, which makes the physical decline especially difficult emotionally to navigate. In Western North Carolina, where mobility equipment and home modifications are often unaffordable or unavailable, these symptoms quickly turn into daily barriers to living at home. So without proactive support, families burn out and hospital admissions for complications become extremely common. These patients' monitoring must be extremely detailed. Every symptom and abnormality needs to be documented carefully. Any sudden or sustained neurological change needs to be reported immediately to the medical director. Just as important, community paramedics must assess whether the patient's social network is providing adequate care. In rural communities here, families may be isolated and unable to handle the increasing demands of ALS. Without strong monitoring, key declines are missed and patients may suffer avoidable complications such as aspiration, falls, or infections. Management of ALS is mostly supportive, since there's not a cure, unfortunately. Medications may slightly slow the progression, while others target symptoms such as muscle spasms, drooling, or depression. So there are medications out there. As the disease advances, patients often require full management plans, ventilator support, feeding tubes as well. In our region, gaps in access to respiratory therapy and home health means many patients go without critical interventions. Once again, education. Educate, educate, educate. So this is key for both patients, families, as well as caregivers. The patients need clear explanations as to why the symptoms are happening and what to expect as the disease progresses. Education also includes training on assistive devices such as wheelchairs, ventilators, and feeding tubes. So connecting people with different ALS associations that have equipment loan programs on caregiver training can be helpful. So those things like ALS Associations of North Carolina or Families of Faith is another one. Huntington's disease, onto that one. It is hereditary, progressive neurological disorder caused by a mutation of chromosome 4. The hallmark symptom is chorea, that involuntary jerky movement, but it also brings cognitive decline as well as psychiatric symptoms. Onset is younger, so between 30 and 50 years, and after that the life expectancy is about 15 to 20 years. In our region, specialty care is hard to find, so you may have to take trips for care for Huntington's to Greenville or Chapel Hill as some of our closest locations in our region. Symptoms include fatigue, sedation, restlessness, anxiety, mood swings, and eventual severe cognitive decline. The combination of movement problems and behavioral issues creates enormous stress for caregivers. With no cure and only limited treatments available, most patients require extensive family support. Monitoring for Huntington's is similar to Parkinson's and other neuromuscular diseases. It requires close assessment of both motor and psychiatric symptoms. Any sudden change needs to be reported to the provider or to medical direction. So there's no cure for Huntington's, but one FDA-approved drug, terabenzine, I believe, can reduce the jerky movements. Management focuses on controlling symptoms and maintaining safety. This includes fall prevention, psychiatric care, and nutrition support. Education for Huntington's centers on helping patients and families manage daily life. Key points are going to be see a physician regularly, take medication as prescribed, monitor symptoms, keep a notebook, maintain a balanced diet, exercise when possible, avoid alcohol, nicotine, and stimulants. Locally, social services and faith-based organizations sometimes provide caregiver support, but resources are limited. Without education and planning, families often reach a breaking point, leading to premature nursing home placements. On to MS. Multiple sclerosis is a chronic immune-mediated disease that damages the central nervous system. It is unpredictable, with symptoms ranging from mild to severe. Some patients experience relapsing MS, while others develop progressive forms that worsen steadily. In the U.S., nearly 1 million people live with MS. In Western North Carolina, younger adults with MS often face unemployment and financial hardships when symptoms prevent steady work. Without coordinated care, disability advances quickly. So the symptoms vary widely for MS. They can include numbness, tingling, vision problems, weakness, pain, even paralysis. Some patients may go into remission while others deteriorate rapidly. Because the disease looks different for every patient, it is often misunderstood. A diagnosis of MS is based on a combination of medical history, physical assessment, neurological exam, MRI imaging, and spinal fluid analysis. There is no single definitive test. This makes access to specialty care critical, but many patients in our region face long waits and long drives for these services. MS requires vigilance monitoring with new neurological symptoms or signs of disease progression. Acute changes like vision loss, a sudden onset of weakness, or difficulty walking does need urgent attention. Patients with advanced MS may require around-the-clock care. So in our region, families often try to manage alone. They may miss the early signs of relapse. So without timely monitoring, patients lose their mobility and independence much quicker than necessary. Monitoring also means staying alert for infections, pressure ulcers, and UTIs, which are very common in patients with mobility issues. Devices such as catheters or wheelchairs require frequent checks to avoid complications. So our management focuses on treating relapses quickly with corticosteroids, using plasma exchange for severe episodes, and prescribing disease-modifying therapies to slow the progression. Physical therapy, exercise, and mobility aids also play a major role. Education for MS varies depending on the stage of the disease. Early on, the patients need to understand the unpredictable nature of MS and the importance of follow-up care. In the later stages, education shifts to preventing complications, ensuring skin care, and managing assistive devices. One consistent message is essential across providers so patients don't get conflicting information. So without education, patients may disengage from care and miss critical interventions. Seizures are sudden. You guys probably are all familiar with seizures, I should hope. It's sudden involuntary burst of electrical activity in the brain that causes abnormal movements, or tonic-clonic sensations, or also even weird behaviors to occur. Could be partial, could be full. It may occur as isolated events or as part of epilepsy. Seizures affect over 3 million adults in the United States and are a frequent cause for EMS calls. Without education and clear plans, families often panic during seizures. They end up starting CPR on our post-tictal patients or call 911 unneededly. Seizures can be caused by many factors. Could be stroke, traumatic brain injury, could be alcohol withdrawal, some of the worst, drug overdoses, or brain tumors. We see seizures triggered by poor medication compliance due to the cost of access or access issues. So medications are becoming more expensive. People don't keep up with their medications and they forego it because they have to pay the power bill. We see that a lot in our region. If the underlying cause isn't identified and managed, seizures will continue, increasing the risk of injury and long-term brain damage. Epilepsy is diagnosed after recurrent seizures and involves a combination of physical exams, lab work, imaging, and EEG studies. While we don't diagnose, we can reinforce the importance of specialist referral as well as the follow-up. Monitoring seizures means documenting what happened before, during, and after. So we need to make sure that we are also educating the family as well as the patient. Key details include how long the seizure lasted, the movements that they made, any provoking factors, and the recovery time. Families should be encouraged to keep seizure logs. Without this information, providers may adjust medications incorrectly. Either under-treating or over-treating will end up happening. Self-management is vital. Patients must take medications consistently, keep appointments, track the triggers, adopt healthy lifestyles. Families can help by reinforcing adherence and providing safe environments for these patients. All right, on to the last slide. Education should include seizure first aid, teaching families and friends to roll the patient onto their side, clearing the area of hazards, and the time of the seizures. Families should know when to call 911 and when a seizure can be managed at home. In our region, epilepsy foundations and pediatric neurology clinics in Asheville offer family training, but many rural families are unaware that these even exist. So without education, every seizure feels like an emergency, which could lead to an ER visit. Okay, guys, that wraps up our discussion of our musculoskeletal and tubulometary and neurological conditions and chronic disease management. In our next module, we're going to be starting with slide 125, and we'll finish the series by focusing on pain, the endocrine system, hematological issues, and immunological conditions. So these are equally important because we do connect daily to the kinds of chronic patients we see in Western North Carolina. So take a quick break, and when you're ready, we'll pick back up again and close out the chronic conditions section together. And bye-bye.